Okay, so now that we have a little background on heat transfer in general, we're going to specifically focus on our cold modalities first. And again, specifically those physiological effects and when we would use cold. So this is just a graph from your book. You're getting used to these kind of flow charts. But the physiological effects of cold, when we apply cold, we get a bunch of different effects. One of the main things is that we're trying to decrease tissue temperature. And mainly that is for decreasing cell metabolism, especially when we're talking in the immediate response to an injury. And so when we decrease cell metabolism, we have all of these other side effects that also happen. We slow the sodium calcium pump, we reduce cellular output, we decrease the need for oxygen, and we increase fluid viscosity. So you can see then what happens, and the red shaded are usually our goals, right? Why we would use cold. And so we decrease that secondary injury, right? If we decrease the need for oxygen, that's a huge part of our inflammatory response treatments. Decreased cellular output also decreases inflammation. That limits the total scope of our trauma, which would also help reduce our swelling formation. As same with the viscosity will help decrease blood flow and reduce our swelling formation. All of that ends up leading to pain reduction. Again, slowing the calcium sodium pump also, or the potassium sodium pump is also going to decrease the nerve conduction velocity, increases the depolarization threshold. That will decrease muscle spasms, which also affects pain. That alone also affects pain. We don't sense the pain as quickly because of that increased depolarization. And then over here, we have the pain mechanism. So we get the gate theory. So we get level 1 by feeling the cold. We also get a little bit of that enkephalin release, a little bit of level 2, especially in the early beginnings when we have some of that cold pain that we call it. And all that works to close our gate, which also then reduces pain. And so anything in the red, those are going to be the reasons you would want to use one of these modalities. So keep that in mind. We'll see this graph or this chart a couple times in our presentations just to remind you. These are those indications. Okay, we saw those over in this graph. All of those indications are the things that we see here in our physiological effects are over here. So if we have an acute injury or inflammation, if we have acute, chronic, or post-surgical pain, right? So we'd want to decrease inflammation. We want to decrease pain. If we want to prevent edema formation, we can use it in conjunction with rehab activities. I talked about that in the first video. We can help spasticity from the central nervous system disorders. We can help with acute and chronic muscle spasms. Cold is actually better for muscle spasms than heat is. People tend to like heat because it makes you nice and sleepy and it's warm and you feel better. But in general, cold is actually better. And then neurology or kind of nerve pain as well. The contraindications are going to be really important. Okay, we'll talk about these more too. But basically, for all of our thermal modalities, if the person can't sense the area, or if they have decreased or insufficiency in their circulatory system, we do not want to use modalities, our thermal modalities on there, because their body can't compensate. And so they're more likely to get burns or frostbite. They're more likely to have problems with overheating or overcooling. So anything that really deals with circulatory insufficiency or decreased sensation. We also have our cold hypersensitivity or cold allergies, right? Cold urticaria. Again, anesthetized skin if they can't feel the area. Same with advanced diabetes. That would have to do with the sensation issues. If they have chronic wounds, any uncovered open wounds, we wouldn't want to do cold therapy on, especially our open tubs and things like that. Peripheral vascular disease goes up with the circulatory insufficiencies. Raynaud's phenomenon, remember, is that disorder that causes the vasospastic spasms in the tissue, especially the fingers and the toes. And it can actually be an underlying sign of something much more significant as well. So we'd want to be aware of that if someone's demonstrating that. Lupus or other conditions are problematic. Hemoglobin anemia, so decreased hemoglobin in the blood. cold-induced myocardial ischemia, especially when we're treating larger areas, if we were going to put someone in a tub or something like that. And then our precautional areas for cold. So over the carotid sinus, areas of infection, anywhere near the eyes. Again, any kind of cardiac involvement, respiratory involvement, or hypertension. So what ends up affecting how much cooling that we have? So number of factors are going to affect how effective a certain modality is at cooling the tissue. First one is the temperature differential, or that temperature gradient between the body and the cold modality. So the colder the modality, the quicker the heat loss that we're going to have. We also have regeneration of the body heat, or the modality cooling. So how quickly can the body re-establish its normal core temp? So your body's always going to be trying to keep in homeostasis. So the hypothalamus is going to kick in. So we have to actually overwhelm the body's natural response in order to try to reduce that tissue temperature, or which is the case of cryotherapy, or potentially increase it when we're talking about thermotherapy. So how quickly is the body going to regenerate that heat? And how quickly is the modality going to lose its cold and heat up? The heat storage capacity of the modality. So different modalities can absorb a different amount of heat. So based on what it's made of, based on what the size is, a bunch of things like that. So the size of the cold modality, as we increase the size, we'll increase the heat loss. But we also want to do something that's really efficient and not be wasting a lot of the modality as well. So we want to balance that size. The amount of tissue contact. So this goes back to our equation, right? That surface area. So the more contact means more heat loss. The length of the application. So the longer we apply the treatment, the increase in the heat loss. Remember that the temperature gradient is going to go until both the modality and the tissue in contact with the modality, so specifically the skin, are the same temperature. And so the longer we go, we potentially get more depth of penetration of the cold. We lose more heat deeper, but eventually it will stop because the modality will reach the same temperature as the skin and we won't have any more exchange. But those deeper tissues might continue to cool for several minutes, almost sometimes up to an hour, post removal of the modality, because of the insulation of the adipose tissue and the tissues above. Again, the amount of adipose tissue, so that acts as an insulator. The qualities of the material being used. So this again goes a little bit with the heat storage capacity, but the specific heat equation for that particular modality is essential for what we want to do. So the greater the specific heat of that modality, the increase in the energy that can be withdrawn. So water has a really high specific heat, so it can absorb a lot of energy. Another thing that's important is phase change. So cold modalities like ice that can melt and turn into a liquid, it takes more energy to make that phase change than it does just to lower the temperature of water already 1 degree. So to go from that point of 32 degrees Fahrenheit to 33 degrees Fahrenheit takes more energy than it would just to go from like 33 to 34. And so we get more heat withdrawn during that. If we apply it directly to the skin, insulating layers add to that K in our equation, and they add to the length of the distance. So we pretty much always want to apply directly to the skin for our cold modalities if we can. We have a couple exceptions just for safety reasons, but otherwise we want to go directly to the skin. The rate of the intermittent application. So how often we are putting the cold back on. So typically research shows anywhere between a ratio of 1 to 2 to 1 to 6, which means for every 1 minute on, so if we do a 30-minute treatment, we do 2 minutes off. So that would be a 60 minutes off, or sometimes up to a 1 to 6 ratio. We'll talk about that a little bit more, and it really depends on if we're doing this for immediate care or if we're doing this for kind of our post-immediate care. And then our number of treatment sessions. So how often are we doing this? It kind of goes with our rate of intermittent application. Are we continually or after a brief interruption applying the modality? and then the individuality of the person. So again, the amount of adipose tissue, what are they tolerating, how does their body respond, how is their hypothalamus, how is their sympathetic nervous system. If that is affected, we could have more issues with regulating the cold, so they might get cold faster, different things like that. So when we look at the cryotherapy with those temperature differentials, so the skin, the surface, is going to be the first to start losing its heat. And as the skin cools, it's going to actually draw heat from the lower tissues in order to try to keep this homeostasis level. And then that heat will then leave into the cold modality. So that's how we cool these deeper tissues, is the skin, which is in contact with the cold modality, actually pulls the heat from the deeper tissues. So with a 30-minute ice pack, research has shown a decrease down to about 36 to 45 degrees Fahrenheit, or 20 to 25 degrees Celsius on the skin surface. If you remember back to the previous presentation, we said the skin typically is at about 91 degrees. So that's anywhere from about 50-degree temperature decrease at the skin. So we get immediate and rapid decline at the skin surface, and then it steadily slows, eventually plateauing a few degrees above the temperature of the modality. Again, somewhere around 36 to 45. There'll be things that will affect how that happens. The activity after icing or during icing will affect the degree of cooling. The skin will also be the most quick to rewarm. So that's going to be something to keep in mind too, that the deeper tissue will actually take longer to rewarm than the skin will. When we start moving into our tissues, okay, the depth and type of the tissue is going to affect how much cooling that we have. So subcutaneously, right below the skin surface, follows pretty much with the skin, but a slight decrease in magnitude. As we go deeper, again, trying to target the intermuscular, we do not begin to cool until several minutes after the application of the modality, because again, the skin is the one who's going to have to pull that heat away. So it's going to take a couple minutes for that to start. And then it will decrease gradually, and again, to a lesser magnitude than the subcutaneous in the skin. But it will continue to decrease after the removal. And again, that kind of depends on how deep of the tissue we're talking. And then obviously our adipose tissue will insulate the deeper layers. So it will be harder for us to pull that heat out, but it will also keep it from rewarming as fast. When we talk interarticular, okay, so inside a joint capsule, we get the greatest temperature decrease with cold immersion, so doing like a slush bucket or something like that versus ice packs. The joint will have a greater decrease than the surrounding muscle, because blood flow is really strong in the muscle but not in the joint, and so warm blood isn't going to be coming to the area like it would to the muscle within the joint itself. And so a minimum temperature is usually reached, again, sometime after the removal of the ice bag. The longer the application, the greater that decrease, and rewarming inside the joint capsule can actually be delayed for sometimes several hours after the removal. So the temperature as the temperature of the skin over the joint decreases, the temperature within the joint is also going to decrease really proportionately. It's about 0.65 times less than of the skin's temperature decrease. And so we can get that temperature down about 1.8 degrees in the joint itself in about 60 minutes potentially. Rewarming of that tissue is dependent on a couple different things. So fingers are going to rewarm faster than the rest of the body. That's a defensive mechanism of our body. It's going to be easier for those fingers to warm back up. Activity during post will definitely increase the rewarming rate because more heat becomes available as our cells become active again. So even while moderately walking, that can result in about a 7-degree increase in 20 minutes or a 9.5 degrees increase in about 30 minutes following the treatment. So the ideal situation is no activity. We're going to get more cooling, especially if we're talking in that acute inflammatory stage, that immediate care. We want them doing very little activity between icing because we're trying to keep those temperatures low. So a 20 to 60 minute application will again decrease our tissue temperatures significant enough, and the adipose tissue levels will also increase the rewarming time. So the activity level before we apply, so if our temperature is already raised, that's going to dictate kind of our rewarming because we might lose less to the modality. The amount of heat removed during the application, so how long do we do it, how cold was the modality we applied, things like that, and then the amount of heat available to rewarm. So again, how active are we during that rewarming phase? So this is just factors that we just went through in just a chart from your book. So if this makes more sense than my talking, you can definitely take a screenshot or look in your book for these, but it essentially talks about the same things that we just discussed. So some benchmarks to kind of be aware of when we think about temperatures. So blood flow begins to decrease pretty quickly after the cold modality is applied. At about 13 minutes, the rate of blood flow has decreased and then starts to level out. So it's gotten to its lowest and it'll level out from there. Lymphatic vessels are relatively unaffected by the cold until the temperature reaches about 59 degrees Fahrenheit. And then the cross-sectional area begins to decrease of the lymphatic vessels. So if we go below 59 degrees Fahrenheit, then we'll actually be decreasing the lymphatic activity. But otherwise, they stay relatively the same. So we can get all the good benefits of decreasing inflammation without affecting the removal of those fluids. Tissue temperatures have to reach somewhere between 50 and 59 degrees to maximize that decrease in cell metabolism. So again, our immediate care is going to be really important there. And then neurological changes begin to occur when the skin temperature decreases about 9 degrees Fahrenheit. So that's when we're going to actually start to see the pain changes and the changes in the velocity of the nerve fibers. And then maximum analgesia is obtained when the skin temperature is decreased to approximately 58 degrees Fahrenheit. So we'll get kind of maximum pain relief around there. And then sensation will start to return when the temp gets to about 60. So what are some of those sensations? So anyone who's ever put on cold knows it doesn't actually feel all that great right away. And that's because we actually go through a little bit of a pain response to cold because of the thermoreceptors. So the first thing we usually feel is cold. We feel it being really cold. Then we get into a burning, okay, and it kind of burns, and that can be confusing because you're cold, but it's again our thermoreceptors, what they're sensing. Aching, and then we get to numbness. So because of that burning, aching time, that may deter a patient's compliance. And so it's really important to us for educating people about those expected sensations and let them know that the treatment will become more tolerable. And actually, the more we do it, the easier it is for the patient to get to that numbness point. But we want to warn them of those 4 signs. So when we go to do our competencies, you're always going to have to warn about those 4 sensations that the individual is going to go through. This is especially important when we're talking about using ice water immersion or a slush bath. So analgesia, the absence of pain, is obtained about 18 to 21 minutes after a cold application, and that will be sooner with ice water immersion as well. So usually that burning, cold, aching is going to last anywhere from about 3 to 5 minutes up to about 15, depending on the sensation, on the type of modality that we have. So again, just back to this chart. So we've seen some of these physiological reasons that this happens. Now we'll go into specifically what's happening to create these different goals. So cold's effect on the cellular response. Okay, cold is going to decrease cell metabolism and decrease the rate of damaging cellular reactions because it decreases the amount of oxygen needed then. So we're going to actually be able to affect that secondary cell death by reducing the cell's metabolic load. They're going to be able to stay alive longer when those oxygen levels are really low during the inflammatory response phase. So we decrease our total injury layer, which was down here, right? We decrease the total scope of the trauma because we can decrease secondary cell death. On inflammation, cold's application is going to suppress the inflammatory response. So it's going to reduce the release of inflammatory mediators. It's going to decrease prostaglandin synthesis, decrease capillary permeability, decreased leukocyte interaction, and creatine kinase, which a lot of those are important for the inflammatory process. So again, we want to balance our cold use with the need to decrease secondary cell death, but we don't want to overdo cold longer into the healing process that we end up affecting the actual healing. The blood and fluid dynamics, we get arterial vasoconstriction. Also, when we cool a liquid, it becomes thicker, so we increase our blood viscosity, and both of those work to reduce blood flow. So within edema formation and reduction, cryotherapy limits the formation of edema by reducing cell metabolism. Okay, we talked about that. So if we have less secondary cell death, we're going to have less swelling because there's less injury total. But cold application alone does not promote the removal of edema and actually could hinder venous and lymphatic return. We saw that with that 59 degrees. If we get colder than that, which we will probably do to try to support here, we will actually decrease the lymphatic activity. So again, as we get to that point where lymphatic activity is really important, we need to balance that. But we can help balance some of that with compression and elevation during the cold treatment to help assist that venous return that we're kind of countering with the cold. The nerve conduction velocity. So as we apply cold, we decrease the rate of the nerve impulses that are transmitted, and it also increases our depolarization threshold. So the longer the cooling time are usually required to really get to the deeper nerves. Superficial nerves will be affected more quickly. And this is, again, that idea that for every 1 degree Celsius drop of the intermuscular temperature, we get about a 1.1 to 2.6 meters per second reduction in the nerve conduction velocity. That's significant. So we're definitely going to slow that nerve fiber signal, which is going to slow our pain response and slow the sensation responses. So that's how we help block pain, the analgesic effects of cold. Sensory nerve transmission is more affected than motor nerves. So we get much more slowing with our sensory nerves than we do with our motor nerves. Proprioception and joint position sense. So cold tends to affect how our joints can know their place in space because of that decrease in the nerve conduction velocity. And those deficits may last to 5 to 10 minutes following application. So when we talk about using cold before doing an activity, what we call cryokinetics that we're going to talk about in a different video, we need to monitor that really closely. And this is also one of the reasons why you've heard the adage of let's not ice before activity, because your joint can become a little unaware of where it is. So you need to kind of monitor that really closely. Pain control. Because of that, we get some of the level 1. We get a little bit of the reduction of pain because of reducing inflammation and swelling and those things causing pain. So that's our primary pain control. And then our secondary pain control is our level 1 pain relief, as well as slowing the nerve conduction velocity and things like that. And then our muscle spasms, we get a reduction because we suppress the stretch reflex by, again, changing the threshold and decreasing the sensitivity of the muscle spindles. And so the muscle will actually decrease spasm really effectively with cold. Muscle function, we're going to decrease the nerve conduction velocity, decrease the sensitivity of the muscle spindles, we increase fluid viscosity. All of that kind of decreases our ability to do really rapid muscle movement and to get maximum force. So again, another reason we don't usually ice directly before activity. The exception being when we're going to be talking about cryokinetics, when we really focus on those and are supervising that. So we need to make sure the patient has adequate time to rewarm, usually about 30 minutes before they really go into intense activity. And then muscles that are inhibited, so the change in temperature is going to increase the motor neuron pool excitability. So it's actually going to help when muscles are inhibited to reinstitute those muscle contractions. So during a 20-minute cold application, the neuron excitability is inversely correlated with the temperature. So as the temperature drops, the excitability actually increases. So more motor units are going to be available.